the chapter from last week and this week's chapter, I wanted to go over a couple of things with the papers, the discussion post, and then the test coming up. So the first thing is with the discussion posts, I wanted to remind everyone that they're due by 9:15 the night of class. So this is every single week. Our class ends at 9:15, so the discussion posts are due at 9:15. I think there's been a little bit of confusion about that with maybe like midnight, that kind of thing, but it's due at the end of class. So I suggest, and I've noticed a lot of you guys have posted well ahead of time, like days before, that kind of thing. So keep that in mind. With the papers, the papers I've read so far have been great. You guys are right on track with exactly what I wanted. But there are a couple of things that I've noticed like patterns with. So I wanted to cover that, mainly with APA format. So I didn't take off any points with APA format this time. I'm going to go over that stuff, and then next time if I start to see issues, I may dock a couple points. With that being said, if I notice that you didn't even try APA format at all, then I'll take off points, but I haven't seen that yet. So what I saw was a lot of people didn't change the font for their headers. So for this one, I made this like fake one. The page number is the wrong font, right? So I would change that to Times. You can see how it changed. A couple of other people I've seen had it completely the wrong font, so you just want to make sure everything's Times New Roman. Everything is the same font. Another thing I've seen is, and I talked about this the first day, so this is double space, that's what I want, but something's not quite right. So there's kind of like this extra space, you can't really see here, but between paragraphs something's going on, that's not quite double space. So I would highlight the whole paper. You want to go here, line spacing options, and see there's my problem. So for some reason it automatically put it as 6 points between each paragraph, right? So before. So I want to change that to 0, not auto, 0. So you always want to make sure that's 0. And it kind of brought everything a little bit closer together. Now it looks better. The other thing I saw was some people put 2 spaces between sentences. Typically you want just 1 space between sentences in APA. When I searched on this, you can have 2, but overall the consensus is pretty much 1. So we're going to keep it that way. That's what most people prefer with APA. That's what I'd prefer. Another thing I saw was some people, for the beginnings of paragraphs, maybe spaced over 3 or 5 times and didn't give me a full tab. So I'm going to delete that and click the tab button instead. So that's where a paragraph should start. Other than that, everything was pretty good. A lot of people used their headings. This was really helpful for me, and I'm sure for you too, to keep everything organized. So I suggest that. Here's an example of what headings should look like, and I did see that with the people who used headings. I didn't see an issue, so just keep that in mind. But overall, great papers. Like I said, I'm only taking off points if the paper was late, if you just blatantly didn't use APA format, if the paper was too short. Let's see. So in the syllabus, the paper was supposed to be 3 to 4 pages. I saw quite a few people go over 4 pages. If it's a paragraph over, that's not a big deal. This time around, I'm not taking points off for it. But in the future, try to keep it between 3 and 4. That's part of the difficulty of the paper, which we talked about this the first week of class. Especially when it comes to a reflection paper, you just kind of start typing, and before you know, you're at page 8. So I did see that a few times. Try to keep it shorter, because that leads to me, I end up basically reading 2 different students' papers instead of 1, and it just takes up more time. So I'd rather just read 3 to 4 page paper. So I didn't take off if you went over, but I will take off if you go under. So make sure it's at least 3 full pages. Yeah. So keep that in mind. And then I did take off if there were a ton of grammatical issues. Like I could tell that maybe you didn't go through and reread the paper, or maybe at times it was kind of difficult to understand what you were trying to convey because the grammar was just a little bit off. So I did take off a couple points there with that as well. And that's where I suggest that everyone uses that website Grammarly. So just put your paper through that and you should be fine when it comes to grammar overall. Although you always want to kind of reread your paper before you turn it in. But those are the only reasons I would take off any points. So overall, everyone's been doing great. I haven't seen really any issues, but I wanted to keep everyone up to date with kind of my thought process with grading. Okay, and so the last thing I wanted to check in on was the exam. So like I said, there's 100 questions. Let's go to the exam. 100 questions. It's going to cover all the chapters that we've discussed in class so far. So I think there are 5 chapters. So 20 questions per chapter. Give yourself plenty of time. The test opens at 5:30 and ends at 9:15. This doesn't mean you have to log on at 5:30 and start right then. You can log on a little bit later, but please, please, please don't email me at 9:30 and say you tried to start the exam at 9 or 8:30 and you didn't have enough time, that kind of thing. Like, give yourself plenty of time. Start at 5:30 or 6. 100 questions, I mean, that might take a little while. I'm not trying to trick anyone with the questions. They're very straightforward. It comes directly from the textbook. Most of them are multiple choice. There's a couple true false. If you just have been listening to the lectures and you've read the textbook, you should be perfectly fine. But the only issue I could see is timing. So if someone didn't give themselves enough time or forgot to take the exam, that kind of thing. So just be really careful, set an alarm, remind yourself to take it. Also, like I said, I do throw out questions if I feel that they're a bad question. So if a huge chunk of you guys get them incorrect, I'll look at it. If I feel like, oh, well, this was worded weird or we didn't cover this that well, then I'll throw it out. So if you're nervous about that, keep that in mind as well. And the last thing with the exam is to please contact me if you can't access it for whatever reason. If your internet goes out, somehow get on, I don't know, drive to McDonald's or something and use your cell phone to email me that you can't take the exam. Do something. But if I get emails the next morning or at midnight, it's really hard for me to help you out. So I need to know, and we need to figure out a plan if for some reason you can't take the exam. But I'm much more likely to help you out if you come to me before than after. So just keep that in mind. But that's it for that. And if you have any questions, feel free to email me and ask. Okay. So last week we left off on sexual orientation and heterosexism. And I think we were on slide 13. So cultural intersections of sexual orientation. We've talked about this idea of intersectionality before, I think with every single chapter. This idea that we each have these kind of multiple statuses, right? And I've talked about like the profile, we can all be plotted on it somewhere. So this occurs with sexual orientation as well. This idea of having double or triple minorities, individuals who have 2 or 3 oppressed statuses based on race, culture, gender, or sexual and affectional orientation. So Morales in 1989 came up with a model that can be used with those who are minorities within the gay community, so that intersectionality. So basically they hypothesize that individuals move through different states. So the first one is denying the identity conflict altogether. The second one is labeling themselves as bisexual rather than gay or lesbian. So you can kind of see the step progression. The third one is being conflicted in allegiance between lesbian, gay, and ethnic communities. So the two different communities that they're a part of. And the next one is establishing priorities in allegiance. And then lastly is integrating multiple identities. So you can see here, it's kind of a similar progression as all of the models that we talked about during the first lecture. Something to keep in mind is that people who are of color and are LGB within that community may experience several of the preceding states simultaneously. So this isn't necessarily linear in fashion, and the individual's going through a progression for at least two different orientations, right, or cultures. Consistent with research that ethnic and sexual identity development process occurs during similar periods. So we talked about this before. Most of this development is occurring during late adolescence. So it's kind of happening all at once. Spirituality among individuals who are LGBTQ. So, interestingly, over 3/4 of individuals who identify as LGB are also, they participate in religious organizations. And most of those are Christian. The first one is Protestant, so we see 29.7%, Catholic 19.7%, Born Again Christian would be 17.5%, Wiccans and Pagans 3.1%, Buddhists 2.6%, and Jews 1.2%. And then the remaining quarter, so not the 3/4, the last quarter, they identify as atheist or agnostic. So that's something to keep in mind as well with clients, that 3/4 are part of a religious organization, so they have that cultural aspect as well. Many queer individuals grow up in churches, mosques, or synagogues, and the research shows that they may be subjected to abuse through those religious affiliations. So from the textbook, they define abuse within a religious group as when a religious group or leader, whether intentionally or unintentionally, uses coercion, threats, rejection, condemnation, or manipulation to force the individual into submission of the religious views about sexuality. So these are some messages that might be conveyed, and like I said, intentionally or unintentionally. Some of them, the individual may read into it, that kind of thing, but messages about like feeling dirty, becoming a child molester, your book says, engaging in shameful acts, that kind of thing. So that's something to keep in mind as well. It may affect your patient. And there are a lot of consequences that may come from that, especially if you're working with someone who's going through the development right then, the identity development, so an adolescent, or someone who still hasn't quite reached a cohesive identity, so they're still dealing with it. You might see those consequences of self-loathing, loss of close relationships, maybe poor body image, depression, suicide, lots of issues. And then you also might see some clients, which is more confusing, rejecting their identities. So those LGBTQ identities, just kind of rejecting it altogether, or they might reject the religious aspect of their identity, or they might end up integrating them. So you can see lots of outcomes. So addressing values conflict. We've talked about this with each chapter as well. So it's important for you as a therapist or any type of practitioner to be aware of your own biases. And we have the ACA Code of Ethics. So this is in particular with the counselors in the group. So in 2014, provides clear guidance on a mandate for counselors not to discriminate based on sexual orientation or gender identity. And there are certain standards within there that you can look at, and I'm sure you've talked about it in ethics class. So standard C5, not to discriminate based on sexual orientation or gender identity. Standard C.2.A, practice competently. Standard A.4.B, refrain from imposing your own values on the client. And then we also have these ideas of appropriate referral and termination. So we talked about the Ward versus Wilbanks issue in the past. So this was a practicum student in school counseling. It was Julia Ward, and she was assigned a client who was dealing with depression, but most of the issues were centered on her same-sex relationship. So if you remember, Julia asked her supervisor if she could refer her patient out because she didn't feel comfortable, and the supervisor said no, that goes against the ACA Code of Ethics. And the supervisor ended up, they had a meeting and they decided to dismiss her from the program, basically. That's what happened in the end. And then this court case went on. So something to keep in mind, that even though we can refer because we're not competent to see a certain client, we can't use it as a way of getting out of a certain client that you don't want to work with, if that makes sense. We have to make sure that we're not discriminating with the clients that we see. And part of that means we seek training and supervision for ethical practice. Like I've said in the past, and we've talked about, we all have different experiences and backgrounds. So eventually we are definitely, and probably most clients will see things that we've never seen before. So even though we can refer out because it's not our expertise, that's not something we typically do that often, if that makes sense. We usually seek out training, supervision, consultation, we research, so that we can work with all clients. Okay, so the research shows that LGBTQI individuals do seek out counseling more often than their heterosexual counterparts, so that's something to keep in mind as well. Historically, mental health providers attributed mental health problems to that identity of being LGBTQI without considering environmental effects. So that's something to keep in mind, and I think most people do. So we have attribution bias, cognitive bias that influences how we conclude who or what is responsible for an event. So some stereotypes that we've seen are like fostering self-defeating behaviors, self-persecution, increased psychological distress. In general, individuals who are LGBTQI seek out counseling more than their heterosexual counterparts do, like I said. Individuals who are LGBT are more likely than persons who are heterosexual to experience depression, suicide, anxiety, and substance use disorders. So keeping that in mind when you have clients who identify as LGBTQI, but not assuming that they all have these issues, if that makes sense. Just once again, kind of keeping your ears perked up for all these little red flags to maybe assess further, if not then, in the future. And a big part of this is not necessarily their sexual orientation, but what's going on in their environment, right? So we talked a minute ago about religion and how having some of these internalized negative responses placed on them, like they might be dirty or bad, that kind of thing that can become ingrained in an identity, discrimination, all of these things that are more external can affect the individual. So suicidality and depression. LGBTQI individuals report disproportionately higher numbers of suicidal thoughts and past suicide attempts. They're 7 times more likely to attempt suicide and are overrepresented, so they're more likely to. Suicide attempts are more likely during developmental milestones associated with coming out, which makes sense. So these times of high stress, maybe when they first recognize that they have a same-sex attraction or when they first disclose their sexuality, and this could go even further depending on how they're received. So these kind of, these milestones might disrupt things and make them more depressed. LGBTQI individuals who sought out religious or spiritual assistance were more likely to attempt suicide later than those who received no treatment at all. Bisexual individuals often experience discrimination and intolerance from both heterosexual and gay communities. So this is something that you may or may not be familiar with. Individuals who identify as bisexual are kind of in the middle, and they might have issues fitting in and forming an identity within their heterosexual community, but also within the gay community, and they might experience discrimination from both sides. So something else to keep in mind, more of a feeling of being lost, that kind of thing. So the lack of sense of belonging often leads to feelings of isolation, loneliness, and this can just increase depression and suicidal behavior. Let's see. Another thing to keep in mind is that intersectionality. So individuals who identify as LGBTQI, but also persons of color, they may experience even higher levels of depression or suicidality. So something to keep in mind. So the textbook talks about African American and Latino individuals in particular, that they may be at an increased risk for suicide attempts compared to whites. And suicidal ideation and attempts tend to be higher for Native Americans, Pacific Islanders, and those who identify as multiracial compared to Asians and African Americans, which is, that one's interesting. It stands out to me because if we're looking at suicidality in general, we see higher rates within Native Americans. Although the African American Latino side is interesting because as far as I know, typically it's white individuals who have higher rates than that. We also see individuals who are not religious. It's important to keep in mind those that are elderly. So we'll talk about that community in a moment. Single. There's quite a few little red flags to kind of look out for with suicidality. Male. And I'm sure you all know this, but it's important to keep in mind females are more likely to attempt suicide. Males are more likely to be successful, typically because they use more lethal means. So they're more successful because of that. So keep that in mind as well. Stress and self-esteem. So minority stress. This is the extreme stress experienced among individuals from stigmatized social groups due to their minority status. And there are three main sources. So the first is chronic or acute outward events or conditions. So being bullied, hearing slurs, that kind of thing. The second is the expectation of discriminatory events and anticipatory energy this requires. So kind of always being on guard, being on edge, feeling like at any moment when you enter a room, someone may say something or do something. Internalizing society's negative attitudes and feelings towards those who are LGBT is the third one. Okay. So as with all youth, youth is difficult. It's a period of development. It can be fraught with many challenges related to identity development in particular, exploring intimate relationships, preparing for adulthood, all kinds of stuff. It's very stressful. And you still have that limbic system, coming into play, right? It's not fully formed yet. So lots of emotions, dysregulation. There's a lot going on. Youthhood is very difficult. So it's important to keep that in mind because that's a typical youth, right? That's going through kind of like those typical changes. But when you add an additional component, like the individual being LGBTQI, you might have even more challenges on top of the typical challenges that you see. So LGBTQI youth often lack needed coping strategies. A big coping strategy, like the number one coping strategy for anything, is social support. I think we talked about this in the past. We're social animals, we're social creatures. And that can be a really good buffer for resilience. So individuals who are LGBTQI, the research shows, tend to lack that support. And they tend to lack it with teachers, with family, friends, appropriate role models, that kind of thing. Just kind of a lack of social support altogether. So 85.4% of students who are LGBT were verbally harassed in the previous year with one study. 39.3% reported being physically harassed at school over the same time period because of their sexual orientation. So we do see issues with bullying with these youths. Sexual minority children and youths are more likely than their heterosexual counterparts to be sexually abused or to be abused by a parent. So that's something to keep in mind as well. Kind of have in the back of your mind when you see your client. That might come up later. Many LGBTQI youth attempt to escape and self-medicate their feelings of worthlessness, depression, and anxiety by abusing substances. So they're 3 times more likely to use substances. So another thing to keep in mind. With those substances, this is interesting. We see higher odds of cocaine in particular. So 3.27 to 1 odds. Injection drugs, cigarettes, and alcohol. So those are some ones you might want to look out for. Let's see. So another thing to keep in mind is that a lot of LGBTQI youth end up dropping out of school, and we see a lot of them living on the streets, a lot of homelessness with that group. And the drug use may go along with that. Okay. So social consequences of heterosexism. So we have negative stereotypes. Historically, gay men have been viewed as displaying feminine characteristics and rejecting masculine gender roles, and then lesbians on the other side. There's this stereotype historically that they're very masculine and aggressive and sexually deviant. So that may kind of color some people's views of the LGBTQI community. So keep that in mind. And this is interesting. So some studies examining mental health trainees, in particular, the stereotypes that they may hold about individuals who are LGBTQI. A huge chunk of them believed that most of these individuals have anxiety, personality issues, mood issues, eating issues, and sexual and gender identity disorders. So we can see that a lot of people go into these sessions with kind of these preconceived notions that they assume that the client may have these particular issues. So kind of keeping in mind your biases, making sure that you don't fall into that trap. I think we talked about this before with the LGBTQI population tending to make more money and having higher education status, kind of. But that being kind of, that distorts our view, because we also see that another stereotype would be that they live very extravagant lives because they have these excess financial resources. So that's not always true. Like I said, it can kind of distort what we see, because we also see that a lot of them can't afford to live in, for instance, metropolitan areas where it's more tolerant for them. So this can be an issue. We see a lot of them living in more rural areas, possibly. And we talked about this before, I think last week maybe, with more discrimination occurring in those areas. So keep that in mind. And like I just said, we have a lot of homeless youth. So this could be because of being bullied, having issues at school. Substance use could cause homelessness, being rejected by the family, and the list goes on. So it's important to keep in mind that with the SES of LGBTQI individuals and these stereotypes of having excess financial resources, but that not always being the case, this can kind of lead to this invisibility of poverty. So keep that in mind. Let's see. So between 30 and 40% of homeless youth identifies as LGBTQI. And because they don't attend school, because they drop out, this makes their life even more difficult over time, because they have a hard time finding employment and financially sustaining themselves. So that kind of goes into that issue of SES as well. And this, like I said, it could be being kicked out because maybe they came out and they were turned away by their family. Another thing to keep in mind is that we do see more abuse in the home. So that could be another reason that we see homelessness within this community. And then institutional heterosexism. So anti-gay marriage laws in the past. diminished interpersonal relationships. So internalizing homophobia may prevent individuals who are LGBTQI from reaching out to and participating in the gay community for fear of being identified as gay. So not wanting to join that community. In 1998, both the ACA, American Counseling Association, and the APA, American Psychological Association, passed resolutions opposing prior conceptions that people who are LGB, by their very nature, have mental disorders. So we saw this change. Efforts to alter same-sex or affectional orientation began in the mid-1800s. So this was formerly called reparative therapy. This idea of using psychological approaches to alter or repair sexual orientation. It's now called conversion therapy, and this is the idea of converting an individual. And the current umbrella term, well, I guess the term used now is sexual orientation change efforts. So it's kind of like an umbrella term for all of these things. So in the past, we've seen some pretty outrageous techniques used: excessive bicycle riding, testicle transplants, exorcisms, electroshock therapy. For those of you who do not know, electroshock therapy is still used today. And it can be a very helpful treatment. It's not used very often. It would be for unresponsive depression, like everything else has been tried. So it's a last-ditch effort. The individual is put to sleep for the treatment. It's usually I think 5 treatments in a row, that kind of thing. It can be helpful. But back in the day, people were awake and it was terrifying and not good. So that's more of what this is referring to. Forcing men to engage in sexual activity with female prostitutes, aversion therapy, and hypnosis. So all of these have been used in the past. And we've seen a lot of negative side effects and consequences of these treatments, so which makes sense. That would be very traumatizing. So this actually led to increased depression, anxiety, intimacy avoidance, sexual dysfunction, internalized heterosexism, and suicidality. Okay, so LGB affirmative counseling. I think we've maybe touched on the idea of affirmative counseling before, and we will again with the next chapter. The idea here is that the counselor is aware of their own strengths and weaknesses in working with LGB clients. They're able to use a variety of counseling interventions, and the overall idea is countering the negative messages that have maybe been internalized by the client. So affirming their identities, being very positive, non-pathologizing, and understanding the various issues, environmental issues that might be affecting the client. So this would be in that positive psychology realm that we've talked about before, kind of going past baseline into growing and strengths and self-actualization and finding strengths for the client and coping and resilience, all of that stuff. Okay. So just like everything else we've talked about, we have competencies for the specific group. So the Association for Lesbian, Gay, Bisexual, Transgender Issues in Counseling, which is a division of the ACA, developed competencies. And I did want to note, so last week I mentioned that I think this was against what your textbook said, because I think your textbook might be a little outdated. So there are competencies for working with males in particular in therapy, and that did come out fairly recently, like within the last couple of years. So I did want to make sure that everyone knew that because I brought it up. So with working with LGBTQI clients, these competencies lay out that the counselors should engage in self-exploration, explore resources, do the research, emphasis non-traditional approaches to therapy like that affirmative counseling, become familiar with constructs of discourse, positioning, and deconstruction. So a lot of the same kind of overall ideas that have come up with working with other clients as well. Also be aware of attitudes. Like we've said, LGBTQI individuals are more likely to seek out counseling services. So this is a population you're very likely to work with. So these are good things to kind of keep in mind. Educate yourself and become culturally competent like you're doing right now in class. Explore meanings of gender identity and sexual orientation. Critically examine theories of counseling. Examine the power behind language that's used with your clients. And another interesting thing to keep in mind is that research shows that individuals who are LGBTQI actually report greater dissatisfaction with the services that they receive. So they're more likely to seek out services and more likely to be dissatisfied. So it's important to do what we can as counselors to help them out. Another thing to keep in mind is expanding on the meaning of the word family. So like I said earlier, a lot of these individuals are or have experienced homelessness. They may have been pushed out of their family or left their family. So when they talk about family, it might be very close friends, people who have kind of adopted them in as a family, which you would kind of want to keep this kind of stuff in mind with any client you work with, but with this group in particular. Don't assume that their presenting problem is related to their gender or sexual orientation. Collaborate with them, exploring that environment that we talked about earlier, how that might be affecting what's going on, their issues. Assess for discrimination, harassment, violence, abuse, all of that stuff, because we know that it's likely to have happened with these individuals, and then implement those competencies we talked about. Lastly, with the social piece, we want to try to lobby and support policy change, give back to the community. So this could be giving a talk or presentation, that kind of thing. Collaborate with other fields. All of these things can be helpful and we should do as counselors. So that's it for that chapter. And the next chapter is disability, ableism, and ageism. Okay, so first the textbook defines disability, a disqualification, restriction, or disadvantage, or limitation in the ability to pursue an occupation because of a physical or mental impairment. But it's important to keep in mind that the definition of disability does vary, especially depending on kind of what service you're talking to. So we'll talk about that a bit in a second. It is not considered a universal concept, and many cultures and languages do not have a single word to define it either. So that's important to keep in mind. So different societies from around the world seemingly tend to group together individuals with specific types of disabilities, so for example, blindness or paralysis, and respond to these groups differently depending on the cultural and social interpretations associated with the specific disability. So 4 commonly recognized definitions. So we have Social Security Administration, and I do want to mention that the reason I decided to put this chapter in the course is because this is a group of people, those who are disabled and the aging population, that I've actually seen a lot of in the many different systems that I've worked in, and I don't feel like it was discussed much or enough in my training, so I wanted to make sure we talk about it. Social Security, all of these things come up nonstop with clients, and there are all these words and programs, and it's hard to keep up and keep track. So if we kind of have that information before we go into counseling sessions, then we can help them out better. So I wanted to kind of give you guys a taste of it so it's not out of nowhere. So Social Security Administration, disability is defined as due to any medically determined physical or mental impairment diagnosed by a medical provider to constitute a total disability. So this is like a medical thing. There are 2 national benefits programs. We have Social Security Disability Insurance and Supplemental Security Income. So the first one, SSDI, eligible individuals who have a previous work history and have paid into the system. So those who have worked, they've paid taxes, and then for whatever reason they're unable to work anymore, or they can no longer adjust to work in a different job. They can't work at their old one or a new one. The next one, SSI, Supplemental Security Income, defines disability not by its effect on one's ability to perform work, but rather by the individual's income, assets, and net worth. So that's the difference there. The next one is Americans with Disabilities Act, ADA. So here, disability is a physical or mental impairment that substantially limits one or more major life activities. So this could be, there's a range. It can include physiological disorders or conditions, so cosmetic disfigurement, anatomical loss, psychological disorders. Major life activity includes, so we've got the aspect of the impairment and then the life activity being disrupted. That could be caring for oneself, performing manual tasks, seeing, hearing, speaking, breathing, walking and working, sitting, standing, walking, lifting, reaching. So lots going on there. Okay, so then the last one is state vocational rehabilitation programs. I skipped one. So the IDEA, Individuals with Disability Education Improvement Act. So this is specifically with kids. So school-age children, disability is defined as a physical or mental impairment that adversely affects their educational performance. So that's kind of the piece there is the education. And then the last one is state vocational rehabilitation programs. So here, disability is a physical or mental impairment that cannot be acute or of an emergency nature, so to speak chronic, and must be stable or slowly progressive. So that's kind of a breakdown of our major ways of defining disability depending on what we're working with. Okay, so types of disability. It's very broad, and you may encounter a broad number of types of disabilities, and some are visible and some are invisible. So those are things to keep in mind as well. I think these are pretty straightforward. Yeah. So in 2012, the U.S. Census Bureau reported that 56 million people, so that's 18.7% living in the U.S., have a disability. And more than 38 million, so 12.6%, live with a severe disability. So 30 million people with a disability are reported to be between the ages of 21 and 64. And this is considered to be the working age. So that's important. Approximately 4 million children ages 6 to 14 have a disability. About 50% of people over the age of 65 and 72% of people aged over 80 have a disability. 19.9% of females in the U.S. and 16.9% of males. So we see higher stats with females, which I'm sure there's lots of things that go into play there. If it's a disability caused by a work accident, for example, a male might be engaged in more risky behaviors with the job that they're doing, so they may have passed away instead of becoming disabled. So things like that to keep in mind. Statistics also don't include soldiers injured, so those are separate statistics because that really would have skewed the data. So people with disability who live in institutions as well, they're kept out. This could be a nursing home, mental health facility, psychiatric hospital. So what we're saying here is that the number of individuals with disabilities in the U.S. is probably actually higher than this 56 million people, because two big chunks that probably have a lot of individuals who are disabled are not even being taken into account with these stats. Okay. So there are 4 broad models of disability. The first one is biomedical, then functional, environmental, and sociopolitical, or it's also called social sometimes. So there's been a gradual shift away from the medical model and towards more of a social model. And we've seen this in the field of psychology in general. But overall, with the biomedical model, there's this idea that the individual can be cured, we can manage the disability, we can use healthcare related services, surgeries, procedures, diagnostic tests, adaptive devices, all these very medical procedures and medical jargon. That's what we think of with the biomedical model. There's pathology that can be cured, right? With the social model, so we go from being able to fix the individual to the social model, which focuses on societal barriers and biases against people with disabilities rather than on the person, the disability, or the medical condition itself. So it's less of an issue with the disability and the medical problems as it is society. So failing to embrace or accommodate the person, and that's more of the issue that we see with the disability. So limitations experienced by people with disability are what defines the disability. So not the disability itself, but how it limits their ability to interact with society. The counseling process falls nicely in line with this model because there's a focus of helping process on the strengths, interests, abilities of each person, not so much on the diagnosis, the weakness, or the deficit. So once again, we say we're moving more towards a positive, that positive psychology realm, going past baseline, getting into resilience. Variations on the social model of disability. So this implies that disability is more than the individual's difference and includes attributes outside of the individual, so more socially or culturally based. The disability is highly correlated with low education, poverty, community setting, and environment and low resources. So keeping that in mind. In 25 to 64-year-olds with a severe disability, there's an increased likelihood of living below the poverty line, having fair to poor health status, receiving public assistance, having Medicare or Medicaid, and having an annual household income of less than $20,000. Okay, so the classic model within that social model is that there's an emphasis on the relationship among 4 main factors. So pathology, impairment, functional limitation, and disability. So with the pathology or diagnosis aspect, we see that the individual's diagnosis, disease, injury, condition, or illness. So that's what we see there. With the impairment aspect, this is the individual's dysfunction in a specific body system. Functional limitation is individual's ability to perform daily life activities. So for example, walking, reading, speaking. And then the disability aspect is the individual's difficulty in doing basic activities. So work, household management, hobbies, social interactions. Okay, so this model considers risk factors like low socioeconomic status, chronic health conditions, poor health habits, poor access to health care. The model also takes into account extra individual intervention strategies, so effective medical and rehabilitative care, caregiver support, adaptive or assistive devices, social service programs, and structural or architectural modifications. So these are things that come up a lot with individuals who have disabilities. And this is kind of where our work as a counselor within the advocacy realm really comes into play. I saw this a lot with the VA, especially, which they have a lot of resources, so it becomes more difficult if you're in private practice, that kind of thing. But helping clients to receive these services and kind of becoming a guide for them in a way. It also takes into account intra-individual interventions. So lifestyle and behavioral changes, psychological attributes, coping strategies, activity accommodations that help the person maintain independence for as long as possible. So different societies view people with disabilities with different challenges based on beliefs and biases of that particular society. So that's something to keep in mind as well, getting into that cultural aspect. So an example from the textbook talked about individuals with Southeast Asian background may, not always, but may view a person with blindness in a favorable way. And they may believe that a person who is blind possesses a specific and valued insight. On the other hand, we may see that individuals in Western societies may view that same individual as someone who just has a visual disability and can't see. So we see various roles may intersect when counseling individuals with a disability. So 3 of the roles are the individual, the family, and the community. So all of these things kind of come into play in like a systems approach. So the role of the individual, this person is expected to have what their role they're expected to have in the community. It may influence their willingness of the community to integrate the person into the culture. Conflicts can occur in trying to balance the person's need and expectations, as well as the concerns of the family and community against that person's plans and aspirations for life, both now and in the future. The role of the family. So this could be the extended family, not necessarily the nuclear family, especially if you're working with someone who is not of the Western culture. We see that 94% of world societies really feel that the extended family is very important, not just the nuclear family. So that's more of the norm outside of Western culture a lot of the time. And that might influence where a person lives, works, marries, or even seeks health care. So something to keep in mind. Another thing is Western views of rehabilitation and counseling might actually be at odds with the individual who may be from another culture or society with regard to their very basic rights and specific cultural beliefs. So that's something to keep in mind as well. And then the last one is the role of community. So in the United States, persons with a disability obtaining employment is a primary goal of rehabilitation. But you might see an individual from a different culture may view this as even like abusive towards the individual with a disability to expect them to work or force them to work. It might be seen as neglectful by the family. Okay. So when it comes to counseling individuals with a disability, there's a subgroup of clients with a disability who are seeking counseling in greater numbers, and that is combat soldiers and veterans with physical or psychological war wounds. So we do see this more often. And part of this is the change in the times. It used to be more stigmatized to seek out help. Other things to keep in mind. I've seen a lot of soldiers and veterans seek out therapy outside of like the VA or the military. Sometimes if they're active because they don't want the military to know that they're seeking out counseling. So that's something to keep in mind. You see that a lot actually with Air Force members, pilots. They can have their license taken away. They could lose their position if it's known that they are seeking services. So a lot of them avoid services, or they might seek services outside at a private practice, pay cash, that kind of thing. So you may see more of that and kind of keep that in mind. And combat veterans have higher rates of polytrauma. So this is 2 or more permanent injuries to the body that result in physical, cognitive, psychological, or psychosocial impairment and functional disability. And then we have some examples there. We also see PTSD, advances in body armor, technology, medical and scientific advances, all of these things has enabled over 90% of veterans injured to survive with injuries that would have been fatal in the past. So we see extremely traumatic physical injuries that someone may have died from before, but is now living through. So, we see higher rates of PTSD because of that and living through that and processing it. For every service member killed in a war, it's estimated that 16 wounded veterans will return to the U.S. with some form of disability. So we see really high rates of disability here. It's important for counselors to keep in mind that we might need to change from the we mentality of being in the military to an I mentality in order to plan and achieve goals. So kind of honing in on that. Cultural background is important. Military background is important. Service members' strengths and limitations are important to identify, and this can help kind of overcome some of those barriers. Okay, so ableism. This refers to social attitudes, rehabilitation, counseling practices, and policies that favor individuals who have or are perceived as having full physical and mental health abilities. So in contrast, individuals with disabilities are excluded from social power and full access to services and resources. And we see this every day, and a lot of times we don't realize it at all. If you know someone with a disability, you might be a little more aware of it, or if you have a disability yourself. But something as simple as like going to a class, if there's a couple of steps to get up to the building, that could be a huge issue for someone with a physical disability. If the elevator is always broken, if the class is put on the second floor, little things like that we might never think about if we don't have a disability might kind of come up all day, every day for an individual who does have a disability. So keeping that in mind, and that can be a lot of stress. Another thing to keep in mind is language. The textbook shows like a chart of some things that people typically say, trying to be positive and helpful and nice, but there can be some negative things that are pulled from that, if that makes sense. So calling an individual with a disability brave, that might imply that they're weak and they're being brave because they have this weakness. Calling them courageous, it might be implied that they're unfortunate, inspirational, they might feel pitied. So language is very important. Another thing, language in general with all mental health disorders and with disabilities, any of these things, you always want to be very careful not to label the person as their disability or their diagnosis. So you might hear people say that bipolar client, like that kind of thing. Like that doesn't define who they are. They're an individual who has bipolar disorder, or the client who is diagnosed with bipolar disorder. So same thing with disabilities as well. The individual is deaf, not they are deaf. That doesn't define them. Okay. So in order to be sensitive to clients who have disabilities, counselors need to reach a certain level of awareness, knowledge, and skills. So the awareness is just becoming more aware in general of ableism and how it might affect those who have disabilities. So just kind of keeping your eyes a little more open, becoming a social advocate, becoming more directly involved with helping clients overcome barriers. The next one is knowledge. So knowing that the population of individuals with a disability is probably one of our country's largest minority groups. That's something that we don't tend to think about. The view of disability in the U.S. is treating it as a military matter and the unfortunate outcome of patriotic service. So that's kind of where we started in the U.S., especially when it comes to military members. Then it moved into seeing them as an unintended consequence of the Industrial Revolution, then promoting it as a societal cause for charitable treatment. And now we're to the point where we consider it as an indication of membership in a minority group with a push for empowerment and equal rights. So kind of knowing this history of individuals who have disabilities and what they kind of had to deal with. And then research, of course, always research everything. And the last one is skills. So fully and continually assessing both the client's feelings about his or her experiences with having a disability, and then your experiences as a counselor. And it's important to keep in mind that a lot of clients will view their disability as like a very foundational part of who they are, their identity, and it's not necessarily seen as a negative aspect of them, but there are a lot of positive parts that come with it as well. So we talked about this in the past with like meaning making, that kind of things, same idea. Another thing to keep in mind with skills is to try to minimize the power differential. We're always kind of trying to do that with clients. We can't do it fully because we are the expert that they're coming to see for help, but kind of trying to be more collaborative and work together through the counseling relationship. So disability affirmative counseling, DAT. So you see affirmative counseling again. So this is very positive. It extends from the social model. It views individuals with disabilities as having value and worth rather than being deviant or pathological. So looking at the positive sides of having a disability. It considers multi-systemic implications of disability, so the political, the legal, economic, educational. So it's not just limited to the personal impact on the client with the disability. It's kind of taking it beyond that with the environment. Counselors practicing DAT deal with complex intersections of disability with gender, race, religion, sexual orientation, and other characteristics. It helps clients take responsibility for their disability, manage and prevent the internalization of those negative reactions, and feel important connections with peers and family members. Talk openly with clients about disabilities, locate information about specific disabilities, pursue reasonable and accessible accommodations, and refer clients to relevant support groups. So kind of that advocacy piece again. Okay. So now we're going to get into age. This is the last part. So by the year 2030, 20% of the population will be comprised of older adults. 45 million Americans are 65 and over. In the 1900s, the average person was expected to live 47 years. And in 2015, the average person, it was 76.4 for males, 81.2 for females. And this is all races combined. So we've seen people are living longer overall. Over 3 in 5 people in this age group, elderly population, are female. And over the next 40 to 50 years, the number of people over 65 is expected to double, and the number of people over 85 is expected to triple. People are living longer and longer. Minority populations are also living longer and getting older. So U.S. senior citizens as a group are becoming more racially diverse. And the biggest change by the turn of the 22nd century is expected to be in the number of older men. So baby boomers, this is individuals born between the years of 1946 and 1964. And we see that the advancing age of baby boomers, increased life expectancy of older adults, increased racial and ethnic diversity that we just talked about, will put more emphasis on social policies that directly benefit older adults. So counselors must be ready to assess and treat aging-related issues effectively and competently. Ageism, the textbook definition is the assumption that chronological age is the main determinant of human characteristics and that one age is better than another. So this is a form of discrimination, and it's against those who have higher vulnerability, maybe less access to resources and power. Let's see. The next one is adultism. So this is discrimination against young people and children. So believing that youth and children may be ignorant, untrustworthy, and predictable, and maybe even have nothing to contribute to society or their own well-being. Adults believe that they can and should exert control over young people, tell them what to do, exert control over their life, and this may create a sense of oppression and disempowerment among younger people. So older Americans have distinct psychological and physical issues associated with aging. and that may result in experiences with ageism. So physical changes, we can see changes in skin, so wrinkles, skin elasticity, hair may become thinner, grayer, voices softer, weaker, height may shorten, mobility, so these individuals may have a slower gait or be a little off balance. We also see age-related medical or health conditions, so this could be cancer, cardiovascular disease, arthritis, osteoporosis, and we see that in particular, especially with women. And 88% of people over the age of 65 have at least one chronic health condition. So all things to keep in mind. With psychological concerns, we see physical changes may affect the individual's self-concept, having reduced independence and ability to take care of themselves. So things that they used to be able to do no problem, they've done their whole life, 70 years, and suddenly they can't do anymore. And that can really affect an individual. Dementia. So almost 10% of people older than the age of 65 develop dementia, and this risk doubles about every 5 years after that. Losses, so loss of spouse, family members, aging friends. This can affect someone's psyche as well. And lots of grief, maybe prolonged and frequent. And then socioeconomic and employment issues. So in the U.S. and most Western societies, views of older people generally have been based on function of their economy, so what they're able to do. 13% of older adults live below the poverty line, compared to 14.8% of younger people. The Social Security Administration's definition of retirement age has been extended. So traditionally, the normal age of retirement was 65 years, and currently it's 67 for all people born after 1959. So something to keep in mind as well. And then age discrimination, so denying a job or promotion to someone because of their age, and this is illegal in the United States. Because of the U.S. Age Discrimination in Employment Act of 1986. So that protects workers over the age of 40. Ageism and older Americans. So the Older Americans Act amendments of 2006 protects the rights of older people who, under this act, are entitled to all of these things. So adequate retirement, in accordance with the American standard of living, the best physical and mental health which science can make available, the ability to obtain and maintain suitable housing that they select themselves, that they design, located where they can be around their special needs, full restorative services for those needing institutional care, opportunities for employment without discrimination, retirement in health, honor, and dignity, participation in civic, cultural, educational, and training and recreational opportunities, efficient community services such as low-cost transportation, immediate benefit from research that offers knowledge about health and happiness, freedom and independence, the ability to plan and manage their own lives. And overall, the counselor's role is to facilitate the guiding of the older client. Aging individuals are accustomed to being independent, so you don't want to go in and kind of take over and tell them what to do. You want to kind of help them out and just kind of guide them through everything so that they can make more informed decisions. And we want to show respect for their years of life experience. There is a subset of counselors who work specifically with older individuals. So we have gerontological counselors. And these are ones who specialize in working with aging and older clients. They provide counseling services to elderly clients and their families when faced with changing lifestyles as they grow older. So although most citizens age 65 and older do not have a disability, they are at increased risk. So it's important to consider a relational perspective. So this is the view that aging and disability process is dynamic. It's an interaction between cultural norms and socioeconomic status. And the last thing with age and ageism is having awareness, knowledge, skills, to help our clients. So awareness would be being aware of our attitudes towards individuals of various age groups. It can be manifested in multiple ways. So assumptions of limitations, positive or negative stereotypes about younger or older persons, belief that children and youth might not be as competent as adults, belief that one's mental health needs decrease with age. That's not true at all. Belief that older people have been socialized to handle their own problems. It's not true either. With knowledge, we have the ACA Gerontological Competencies of 1990. So if you're interested in working in this population, or if you have any older clients, this might be something that you look into. And then the CACREP standards. Counselors interested in working with this population may also want to investigate available professional and community resources. So, do the research. Skills, counselors should help clients to build resiliency on positive aspects of aging, understanding that aging is inevitable and that we can be successful in that outcome. So successful aging is the avoidance of disease and disability, the maintenance of cognitive and physical function, and sustained engagement with life. And this can be aspirational because this assumes that people have resources to live a mentally healthy life, adequate access to healthcare, safe living environment, the ability to make their own decisions. And this isn't always true. So keeping that in mind as well. And successful aging might be more so determined by the particular client that's going through the process than this, overarching definition. So, all right. So that is it. So you now have all of the information for the midterm. Like I said, it's 100 questions. Each question's worth 1 point. Email me if you have any questions, if anything comes up. But that's it for tonight.